time we have to start. I'm sorry طبعا for the audience which is nearly absent, and this is a very bad habit in Egyptians. They do not respect time. احنا النهارده هنبتدي الفيرست symposium about ambulatory blood pressure recording. Ambulatory blood pressure recording is a very important test when it is directed in the right way. We are not able to do ambulatory blood pressure monitoring for every patient with hypertension, but we have to select whom are the patients whom are going to benefit from this study, because always when we are doing investigation, the cost-benefit ratio of any study we are doing should be in mind. I think that blood pressure monitoring is important in many aspects, like resistant hypertension, white coat hypertension, masked hypertension, and so on. النهارده ابننا العزيز الدكتور هيثم سليمان هيقدم أول presentation على how to interpret 24-hour ambulatory blood pressure recording, which is very important to be elicited. اتفضل يا هيثم.
Thank you so much دكتور عمر. أستاذ العزيز، هو حضرتك في 3-4 كلمات لخصت تقريبا نص المحاضرة اللي هتتقال. طيب، احنا in order to find something you must know how to search and what you search for. عشان كده لأن كل investigation لو أنا مش عارف إيه الحاجات اللي أنا هاخدها من الانفستيجيشن دي، I will be lost with the information. I can skip an important information and I can misdiagnose or mismanage my patients. So it's with no doubt that ambulatory blood pressure monitoring is one of the cornerstones in diagnosing hypertension in every algorithm. And the British Society and the NICE guidelines consider the ambulatory blood pressure monitoring is a cornerstone in diagnosing and in following up the patient and evaluation even of the intensity of treatment of this patient. And it uses the ambulatory blood pressure even in modifying the treatment of the patient. So it is without doubt a cornerstone in diagnosing and managing hypertension. But regarding it's not available in every center, and it's costly for the common practice. So the most important indications in using ambulatory blood pressure monitoring is the identification of white coat hypertension and white coat effect, identification of masked hypertension, differentiation between apparent and true resistant hypertension, identifying the concern-full patient versus the non-dipper and the morning surges, and which is, I find, one of the most important indication of ambulatory blood pressure, masking the hypotensive events that many patients suffer from and complaining from when are treated with hypertension. Many patients, especially the elderlies, reported some attacks of dizziness, lack of concentration, and even near syncope. And the office blood pressure readings are normal or perfect, so masking the hypotensive episodes of these patients is of utmost importance. And this is the fancy report we get from the ambulatory blood pressure. A colorful, very nice graph and some readings, but we must know what to search for in these readings and to make sure that this ambulatory blood pressure report is valid to take its results. So what we really should know about numbers, first, that ambulatory blood pressure should represent, or the valid readings should represent at least 70% of all readings taken by the device, which represents 70% of the 24-hour. At least we need 14 valid readings for this report to be dependable. If less, and we can repeat this test, kindly repeat the test. This is not a reliable test. and we should adjust the device to read at least every 30 minutes at the morning time and at least every hour during sleep. So this is the first number to look upon, which is the validity of the test. Here the validity of the test is 100%, more than 70%, and the total readings are 42, which represent a safe amount of readings to be considered or be taken upon. The second is the problems that the patient can face when applying the ambulatory blood pressure. The uncomfortable or painful inflations, the failure to inflate, whether the tubes are blocked, are leaked, or the battery failed, removing the device during sleep, which the patient can deny unless you emphasize the importance of keeping the device during the day and during the night, and the excessive movement during recording, especially for athletes, because this intense movement can induce false readings in the report. And one of the most important thresholds is this threshold. We all know that thresholds of hypertension in ambulatory blood pressure, which is over 24 hours, over 130 over 80, the daytime over 135 over 85, and the nighttime over 120 over 70. But what does it mean that the percent allowed above limit is more than 25%? We can have a peak readings every now and then in the ambulatory blood pressure report, and this doesn't reflect that this patient is hypertensive unless these readings above the threshold increases more than 25% of all the readings of this patient. If the patient had, which is a round figure, 100 readings per day, we need more than 25 readings above the threshold to diagnose that this patient is hypertensive. Less than that, the patient is not considered hypertensive and the test is not considered positive. And this is very important because if we don't know this fact and this threshold, we can misdiagnose any patient as hypertensive easily by taking the over readings over the peak readings and consider that this patient is hypertensive. So here, the systolic blood pressure, the above limit was 3 in this patient in the day limits, and the threshold here was only 1 reading above threshold. So this patient have a daytime hypertension or blood pressure above the threshold, and he's a dipper. He doesn't have any elevated threshold at night. So this is very, very important when interpreting the report of ambulatory blood pressure. Anything other to look for? Yes. Some of the terminologies that are not common when reading an ambulatory blood pressure is the hypertensive time index, which is the time the patient spends to be hypertensive throughout the day. And this time correlates thoroughly with the complication the patient can have. And why is that? Because simply the systolic blood pressure time index correlates with the cardiac workload, and the diastolic pressure time index correlates with subendocardial flow supply of blood. So the more the patient spends in hypertension, more it spends with the systolic pressure time index or diastolic time pressure index, the more cardiac workload and the more decrease in the subendocardial flow of blood, which reflects more complication for this patient. And the hypotensive time index, which is simply the time the patient spends in hypotension or decrease in blood pressure. And this is very important when diagnosing a patient that complains of symptoms that suggest hypotension throughout the day. The diurnal index, and the diurnal index is simply when dividing the day and night readings, and they should be less than 10%. And if it's less than that, this means that the night readings are higher, so the ratio is decreasing, and this means non-dipping of the blood pressure, and this correlates well with the complications, especially with stroke. And the morning surge, we know that the blood pressure is peaking during the morning surge, but the higher the morning surge, the higher the stroke liability of this patient and the cardiovascular events of this patient. So these terms must be looked at in every report of the ambulatory blood pressure, because they will reflect the prognosis of the patient and the risk of this patient. So here we are with the report. Mind you that we will discard the first and the last reading, because that is called the white coat window of the patient. The patient is coming eager for the report, or is coming anxious from the device and the process of applying the device. So this is the white coat window. Then the daytime window, the dipping window, and then the morning surge. And this is the normal dipper. The normal dipper has an elevated blood pressure during the morning with its peaks, and then the blood pressure dips or decreases during night time, and then it rises again. The non-dippers have a reversed curve. In this curve, the blood pressure either do not decrease or even increases during the night, which reflects more risk for the patient. And these are the types of dipping. While there is dipper with the blue line, or a non-dipper, which is the black line, or reverse dipper with a blood pressure elevated during the night more than during the day, or extremely reverse dipper with a very high increase in blood pressure during the night comparing to the day. And every line, when we go up, we go up with the risk and complication of the patient. So these are two common patients. One is a 45-year-old female reporting 3 office reading of blood pressure above 150/90. Her clinical examination is normal, ECG is normal, echo is normal. She's not diabetic, dyslipidemic, or smoker, but she's insisting to have hypertension, especially that she's mentioning the sacred symptom for the common people for hypertension, which is headache. And this is the typical curve that we get for a white coat hypertension patient. The patient have 2 peaks, peak with stress, and we must have the diary of the patient, the events of the patient, and what are the stressful conditions the patient faced during the readings. And we can pinpoint that the high readings are the office readings or the white coat zone readings, and the readings when there was stress. The other curve or the rest of the curve is normal. And the other one is the common Egyptian patient, which is elderly, smoker, and on 3 antihypertensive medication. His office readings are below 140/90, but he has S4 at examination, evidence of left ventricular hypertrophy and strain in the ECG, and echo findings of left ventricular hypertrophy and diastolic dysfunction. And when we do the curve to this patient, we discover that the office readings are the least or the lowest readings of them all. But when the patient is subjected to stress, to salt in diet, to any activity, the blood pressure rises. And that's why this patient is having obvious complication of hypertension despite that the office readings are normal. So is the devices differs or can make our life easier? Yes. This is the traditional ambulatory blood pressure device which is carried out. This is another device which is more easier. It contains the cuff and the device attached to each other and can record the readings more easier without the tubes and without the hazards of taking off the device. And in the near future, we will have a reliable devices that are completely electronic, wearable as a watch, either with an inflatable and deflatable cuff like the Omron, or depends completely on the electronic readings. And it can give us a full detailed report about blood pressure of this patient and send this report over the cloud to the treating physician without even the patient coming physically to the office. So in conclusion, ambulatory blood pressure is the most accurate way to diagnose hypertension. The elevated blood pressure readings must be above 25% of all readings. Report can accurately ID white coat and masked hypertension. Report must contain at least 14 valid readings. High morning surge and nocturnal non-dipping carries more risk and complication, and development of small devices will decrease both cost and technical difficulties. And thank you so much.
شكرا يا هيثم على هذه المحاضرة very illustrative. I have some questions. Number one, whether automated blood pressure measuring in the clinic, which is easier for the patient and is not carrying the same problems when he is putting the apparatus for 24 hours, can replace the ambulatory blood pressure monitoring, or what do you think?
In most of the cases and most of the literature now and the algorithm of the European and American guidelines for treating hypertension, it can replace the ambulatory blood pressure in most of the cases, especially if there is technical problems or the patient is uncomfortable of carrying a device. The problem with the automated blood pressure that the device that evaluate the blood pressure is not cheap. So, but it's more reachable and can read more patients during the one session than the automated blood pressure or the ambulatory blood pressure. So it will replace eventually most of the cases that we need an ambulatory blood pressure in. But if the patient is reporting an episodes of hypotension or there is masked hypertension, I don't think that the automated office blood pressure will replace the ambulatory blood pressure in these especially two indications.
So in this condition, we can depend on the automated, and if the patient still have some symptoms, we are not having an answer for that, we can put it beside that.
Yeah.
One other very important point you mentioned, which is the morning surge, which is a normal phenomena, and the most elevated blood pressure readings are coming early hour in the morning when the patient is awaking and after the siesta. So the question now, whether ambulatory blood pressure monitoring, what is the level to tell that the surge is a normal phenomenon? What is the level of the surge we expect that it is above normal? And whether ambulatory blood pressure monitoring in this condition can guide us to the time of giving the medication. For example, if we find that we have a pharmacokinetics for every drug at the peak, where is the peak, and whether we can match that with the timing of the elevation of the blood pressure or not.
If the peak is or the surge is higher than 25% of the mean blood pressure during all the day, this means that this surge is of clinical significance for the patient and for the physician. And as I mentioned, the higher the level, the higher the risk. And elegantly, as you said, you directed us, sir, that the treatment plan is depending upon the time of peak of hypertension and the pharmacokinetics of the drug. Some drugs take from 3 to 5 hours to reach the peak and the peak effect, like some of the beta blockers. So it's wise to give them at night to face the morning surge. Others last for 24 hours and more than 24 hours, so it's not necessarily to give them at an indicated time to have the desirable effect. Thank you.
هيثم شكرا للمحاضرة الجميلة دي. Do we have non-dipper in hypotensive patient?
Non-dipper in hypotensive patients?
Yeah. In our study in the Egyptian population, about 400 patients, we use the 24-hour to know is this patient is normotensive, hypotensive, or hypertensive. And I found this phenomenon and searched for it. There is a non-dipper for hypotension, and this is a dangerous phenomenon. Okay. Therefore, in patient with hypotension, we use usually the 24-hour to know the mean blood pressure. And all the instrument, I think now, is automated to give all this data.
Yes.
In the screen, in the report. Do you recommend the use of 24 hours in every patient with hypertension discovered accidentally?
No, no, because of course the readings and the recommendations differs between societies and between communities based upon the availability and the cost benefit of this patient, and even in all the guidelines algorithms except the NICE guidelines, the use of ambulatory blood pressure monitoring is not the first step to diagnose hypertension or the only step to diagnose hypertension. If this patient is coming with 2 repeated readings of hypertension or even 1 reading with high risk factor and evidence of target organ damage or target-mediated organ damage, this patient is hypertensive. But as I mentioned, this particular or these 4 special situations of muscular hypertension, white coat hypertension, hypotension, are the most suitable for using ambulatory blood pressure and not in every patient.
هو النقطة اللي بيقولها الدكتور سليمان في انجلترا بالذات وكان في نقد لهم ان they are not diagnosing hypertension in any individual except after doing ambulatory blood pressure. وكان الحجة في هذا ان احنا اللي بنشوفه 25% we have a problem in underdiagnosis and in overdiagnosis. So many of the patients taking medication for hypertension, they are actually not hypertensive. All this money is spent without any cause. But if we applied the guidelines for the diagnosis, which meant that we have to have 3 measuring in a matter of 2 weeks, I think this can replace that. Yes. The other point, which Dr. Soliman was mentioned, which is the phenomena of dippers and non-dippers. I think when we are treating a patient with hypertension, we are not depending only on the level of the blood pressure, but on how risky this blood pressure is. So non-dippers is a very important risk phenomena, and I think again we will not discover it except by doing 24 hours.
Yes.
There is some individuals, some groups we are expecting, for example, for diabetics, they have masked hypertension, non-dipper. On those patients may be applying ambulatory blood pressure will be opened. Dr. Shah.
Thank you, Dr. Haytham, for
so
this very nice illustrative talk. I have some comments and a question. I'll start with the question because it's linked to what Professor Soliman has said. What to do if you do ambulatory blood pressure for a patient and you find that more or less he is controlled, but still he is a reverse dipper? And the medications and timing of medications and the long-acting ones are all okay, but you still get that he cannot get back to a normal dipper phenomenon.
The solution is inside the cause. We must investigate this patient and take an accurate diary of this patient, because in a considerable amount of non-dippers, the device is reading that this patient is asleep, and simply this patient have a reversed rhythm of life. He's awake for all the night, and this is misinterpreted, or that this patient has a non-dipping phenomena. Second, we must investigate this patient thoroughly for the diet habit of this patient, because a portion of salt or high salt intake before sleep can cause this non-dipping. And to illustrate whether this patient is having obstructive sleep apnea or not, without reporting it, or even without knowing that he's having obstructive sleep apnea, this will create a hyper dipping, hyper reversed non-dipping, and the patient will not report it, and he's not aware of it.
Yeah.
So many factors can affect it. The last one is the drugs and the timing of having the drugs. So all these factors can give us non-dipping phenomena without treating it.
Okay. One single comment and a request for the Egyptian Hypertension Society. The comment is that you say it's a costly thing and cost effective is a matter. No, because if you get a patient who is not really hypertensive, you spare him the cost of the medications and the long time duration of the therapy. Second thing is, I think the real limiting factor is the process is not very easy to the patient, especially when you apply what you recommend, reading every 30 minutes during daytime and every hour during nighttime. Usually it's just take up the device and throw it. The last thing is a request, I had it many years ago. Why not to get benefit of the pharmacies that usually give false readings, to make a program and we certify the pharmacy and the pharmacist that he is certified to do so.
النهارده احنا عندنا البروجكت ده هو معمول من 7 سنين، واحنا هندسكاس ده الساعة 1 ان شاء الله. لا ونديله سيرتيفيكت. هيثم last comment. If we consider the cost of the 24-hour is costly, it's not costly. If we compare it with the hazards of treatment without benefit and the cost of treatment without benefit, I think it is more or less equal.
One comment about the relative consideration of cost. The consideration of cost is calculated to the nationwide. So not every center and not every clinic can afford to have the device itself. It's not the cost of the test, it's the cost of the device itself. And the national centers and the governmental centers will not have the device available. Then that's why we do not recommend it as the gold standard in treating hypertension or diagnosing hypertension, like the NICE guidelines or the British Society.
شكرا دكتور هيثم.
نقطة أخيرة في موضوع الكوست بنفيت ده. الكوست بنفيت دي should be in the mind of any physician treating the patient. I cannot recommend doing ambulatory blood pressure monitoring for all the patients. It should be directed to the groups of patients, which I think that when I do that, لأن لو إحنا هنفتح ده نعمل كل مش معقول ومش مفيد، لأن الريتيرن مش
هو يعني احنا عن دكتور عمر بيتكلم على نقطة كويسة، خاصة دلوقتي الايكونومي بتاعنا. The majority of the patient, female patient especially over the 50, usually suffering from headache and increased blood pressure. And when you search of the cause, the pain is the cause of hypertension, not the reverse. Therefore, we can use the 24-hour to sacrifice a lot of money. Okay, تفضل. شكرا.